Okay, we'll now continue with the ISAT study. So it will be a little bit dense. So we'll be going slowly. I just want, first of all, to introduce myself. I'm Laurent Spelle. I'm working in this hospital, which is in the south part of the city of Paris. And it was founded in 1630. At that time, it was more or less the beginning of the Romanov dynasty. And slightly later, they have Peter the Great, who founded this beautiful city of St. Petersburg. So Paris is in the middle of the country of France. This is the city of Paris. And if you have never been, this is the Eiffel Tower. If you cross the Seine River, you arrive in the Arc de Triomphe. And then you have a big avenue, which is named the Champs-Élysées, arriving in the Concorde Square. This is the Louvre Museum, which is a former King Palace. Right in the middle of the city, there is an island in which you have the Notre Dame Cathedral, which burned. And if you go 3 kilometers south to the Notre Dame Cathedral, you arrive in the Bicêtre hospital. So this is the hospital I was speaking. So before going to the revolution of the ISAT study, you have to know that it's not a prehistoric period, but during the year of the late 70s, the catheter, they were done in the angio suite. So they were using some flame just to mold. This was done by the technician. The technician, the radiographer, they were molding the microcatheter, and then they were connecting a hub, which was a stopcock, to the plastic tube. There was any medical device company, and this was done some days before the planned treatment. And then they were progressively assembling the microcatheter together. This is picture which were taken by the technologists in my department. At the time, they were working with Jacques Moret and Pierre Lajonias. So you know the discipline was founded by this man who was working at the Bordenko, and for the first time, he was having the idea to occlude a vessel with a balloon. And without him, this specialty would have not existed. At the beginning, there was only some elastic tube, which was provided by the Ball company, and they were using a propulsion chamber. It was connected to the internal carotid artery directly at the level of the neck. And thanks to the pressure you were giving in the propulsion chamber, then you were making the tube flying over. It was not possible to direct this tube. And we found one of the unique remaining propulsion chamber, just to show, and we did a picture movie last year. So this was connected. It was made of glass. You were injecting the water, and you would see the propulsion within the chamber, thanks to the pressure that you have. Look, boom. And then you were trying to navigate. If it was not going in the right vessel, you bring it back, and then you try again. So at that time, they were doing 1 or 2 patients per month, so they had time. It's completely different to what we had nowadays. And then there were some people, they have invented some balloon with a leak, and it was calibrated. It was able to orientate a little bit. There was no guide wire at that time. Also, subtraction was not existing until a very recent time. Even I was a resident, it was done by hand. You had the non-subtracted view, you had the plain view without the vessels, and you had the view with the vessels. and you had to perform manually the subtraction. So how was it working? You took the normal X-ray fields from which you have to obtain a positive. So this is exactly the opposite colors because this will be used to perform the subtraction. So this will be used as a mask. And then you use this mask. You will get here the AVM, which is injected, and you want to subtract the glue and the bone. So you will be using this positive that you got, and carefully you superimpose just to subtract manually the brain. So this technician was doing that when she was younger, and then you put some tape to fix the sandwich, and then having that, you expose that in a specific machine to get finally the subtracted picture. So after it was being exposed in the machine, this is what you were obtaining, the subtracted copy of what you had. And this is the subtraction. So you had to do that for every single picture you were obtaining. Of course, it was taking quite a long time. Then the balloons were used to treat aneurysms, the same balloons that were used by Serbinenko, by Viktor Sheglov in Ukraine now, and Gérard Debrun was working in France. So it was very strange detachable latex balloon. It was attached with a thread of latex, as you can see, and it was inflated within the sac of the aneurysm. And it is because of this past experience Jacques Moret had also. And of course, when you had to inflate the balloon within the aneurysm, when you had a large neck, it was not possible to pull, to detach. And this is why Jacques Moret had the idea at that time, in the late 80s, to use a second balloon just to maintain the first one when you detach it. So this was the first so-called remodeling technique to maintain the first balloon within the second balloon to detach it. And then came the GDC coil provided by Guglielmi, and everybody thought that using a second balloon would be useless. And it is because of his past experience with balloons that Jacques Moret had the idea to use the balloon to better deploy the coils within the sac of the aneurysm. It was a very important revolution, but the biggest revolution was to determine whether or not the coils were more efficient than the clip and what would be the best choice. And this is the rationale for the ISAT study. Because, of course, the temptation was to avoid opening the skull because it's difficult to access and to open the skull. So the ISAT study was published in 2002, and the aim was to compare the safety and the efficiency of endovascular treatment versus surgery. The other objectives were to determine the prevention of rebleeding, the quality of life at 1 year, the frequency of epilepsy, and the cost effectiveness, and the long-term outcome of the treatment and the neuropsychological outcomes. So in 43 centers between 1997 and 2002, each time a patient was arriving in a hospital with a ruptured aneurysm, the surgeon was looking at it and the neuroradiologist was looking at it, and if both agreed they could treat by their technique, then the patient was randomized between the two techniques. And you see that so among this period, they received 2,000 patients, which were randomly allocated 1,000 to the endovascular treatment and 1,000 to neurosurgery. And you see that at 1 year, 800 patients were analyzed in both arms. As far as it is randomized, you see that looking at the severity of the subarachnoid hemorrhage, both groups are completely comparable. If you look at the size of the aneurysm, both groups are strictly the same. If you look at the time between the bleeding and the treatment, both groups look the same. In May 2002, the steering committee with the ethics committee, which follow every randomized study just to check if it's ethical, has decided to stop inclusion of patients, which is very, very infrequent to stop a randomized study. So it has decided to stop including patients and to continue to follow them over time. And this was because there was more disabled and deaths in the group of neurosurgery, 30%, versus 23% in the endovascular group. So that was a decrease of the relative risk of 24% when endovascular treatment was performed compared to neurosurgery. So it was a revolution in some countries. For instance, in my country, most of the aneurysms were already coiled. But in some countries like United Kingdom, it was a complete change in the behavior, and it has to change the practice of treating patients. And especially, they had to quickly train physicians to be able to use coils instead of clips. So then in 2005 was published the whole group of patients. And you remember that if you are looking at the initial result, it was only on the partial population of 800 among the 1,000, because it was stopped by the ethics committee. Now we are looking at the one-year outcome for the whole population of patients that were treated. And looking at the one-year outcome, you see that the results were exactly the same. You had 23% of bad outcome when endovascular versus almost 31% after neurosurgery, keeping in mind that both groups were exactly the same. So the only difference was the method of treatment. So the reduction of the risk at 1 year was almost 24%, which is something which is quite significant, meaning that for every 1,000 patients that you treat, 74 will have a better outcome using endovascular treatment at 1 year. This is what it means. Performing subgroup analysis is interesting. And if you look at the different factors that are affecting the result, you see that when you are in the left, it is in favor of endovascular treatment. When it is in the right, it is favor of the neurosurgical treatment. Here it is in between. So what are in favor of the endovascular treatment? It is the age between 50 and 70. It is a low WFNS grade. It is a low Fisher grade because they better recover. And it is the aneurysm less than 10 millimeters in size. Also, the internal carotid location and the posterior circulation, which is a little bit obvious. Conversely, factors in favor of neurosurgery are middle cerebral location, big aneurysms, old patients, and severe clinical status. And if you look at the cumulative mortality rate, this is the publication of 2005. Interestingly enough, you see that endovascular has a better outcome during the first year, and it is kept this advantage up to 7 years. The advantage is kept for a long time. You don't have a crossover or one curve which is joining the others. Looking at the first follow-up angiogram, you see that you have some number of angiogram. It is common to do it after endovascular procedure, 90%. It's uncommon to do that after surgery. It was obtained only in 50% of the case. Nevertheless, you see that you have a better complete occlusion after neurosurgery compared to endovascular treatment. However, as has been said by Dolly Boccardi, the most important is not the picture, but the clinical result. And if you look at the rebleeding rate from the target aneurysm, before the first procedure, before any kind of treatment, there were more rebleeding in the neurosurgical group. And it has been seen 50 rebleedings among the 2,000 patients that were included in this study. As it is known, 1% per day during the 9 first day, jumped to 4% on the day number 12, and then 2 to 3% between day 11 and day 15, which is something which is known for a very long time. Coming back to the rebleeding rate, you see that you have slightly higher rebleeding rate during the months after the endovascular treatment, but it was not statistically different between the neurosurgical treatment. So it was mainly due this rebleeding rate due to thrombolytic therapy to treat some per-procedural thromboembolic complication or parent vessel occlusion in the endovascular arm. This is why it is forbidden to use thrombolytic therapy when you treat aneurysms in emergency, even the aneurysm is coiled, because it will make the aneurysm bleed again. Don't forget, if you have clot occurring during the endovascular treatment at the acute stage, please never use thrombolytic agent. It will make the aneurysm bleeding again, even it is occluded with coils. Don't forget, if you push coils like crazy inside the aneurysm, only 30% of the volume of aneurysm is filled with coils. So you have always space. If you solve this clot, it will make the aneurysm bleeding again. After 1 year, again, there was no difference between the two groups in the rebleeding rate from the treated aneurysm. So rebleeding during the first year is very low in both groups, 2.4% for the endovascular group versus 1% in the surgical group. So you had the paper in 2002, another paper in 2005. This is the third paper provided in 2009 dealing with long-term follow-up. So I remind you that it's a long-term follow-up between 6 to 15 years. Initially, 1,000 patients were randomized in both arms. Then they were dead people due to the initial disease. They have to be removed. And you have almost 800 patients alive for follow-up. So you see that some of them were lost for follow-up in both groups. Some of them refused the follow-up. And finally, 800 patients were eligible for the follow-up. And if you consider the long-term outcome, there were many questions which were interesting. The first one is, there any increased risk of late rebleeding after coiling? When does rebleeding occur? What is the risk of bleeding from any other aneurysm? Second, will the benefit of coiling seen at 1 year be lost over time? What are the mortality and dependency rate after 5 years? What are the causes of death? We will be going all through these different points. And finally, is this population at greater risk of late death than the rest of population? First question, is there an increased risk of late rebleeding after coiling? We had a follow-up between 6 years and 14 years follow-up, which is a very long follow-up. 14 confirmed rebleeding. 13 of them were rebleeding from the same target aneurysms. 10 in the endovascular group, 3 from the neurosurgical group. No difference between the group in mortality rate as a result of rebleeding. This is the second important result. And if you look at the time for the rebleeding from the target aneurysm, it's almost the same between the neurosurgery in red and the endovascular group. This is the rebleeding risk per year, 0.2 per year in the endovascular group versus 0.08 per year in the neurosurgical group. All events, all bleeding again in the choroid aneurysm, they have all occurred before the year 6. After 1 year, rebleeding risk from a choroid aneurysm is about 0.12% per year. This is the global rate. This is the rate after 1 year. The risk of death or disability from re-rupture is roughly half the rate, which is about 0.07% per year, which is extremely low. What are the mortality and dependency rate at 5 years? 67 patients in the endovascular group have died after 5 years, between 2 to 10, versus 75 in the neurosurgical group. So what were the cause of the death after the rupture and the patient they survived? So here are all the list of the disease, and the most important, very surprisingly, is a high level in cancer and also cardiac disease. These were the most frequent. Are those surviving patients more likely to die than the rest of the population? This is the question. And if you look at the mortality cause calculated from a UK cohort, as it is shown here, you see that the all causes of death, you could expect 92 deaths during this period. It was 46 with endovascular treatment, 46 with neurosurgical treatment. And you see here now the cumulative risk of death for 14 years after the inclusion of the study. And you still have slight advantage after 14 years of the patient being treated through endovascular approach. Probability of survival and independence is 5 years. When the patient is bleeding, what's the percentage of this patient to be totally independent? That's interesting. It is 74% in the endovascular arm versus 71% in the neurosurgical. And now comes, as it has been showed by Dolly, the last paper, 2015. That's incredible because you have 18 years of follow-up. It's very, very uncommon to have such a study. And looking at patients being alive at 10 years, it's tremendously high because you have 80%, 83% in the endovascular arm versus 79% in the neurosurgical arm. Independent is 82% in the endovascular versus 78% in the neurosurgical arm. So you see that the probability of death or being dependent was significantly higher in the neurosurgical group than in the endovascular group. So this is the time to rebleed from the target aneurysm more than 14 years after the treatment. And for sure, the probability to rebleed, as it has been shown, is higher in the endovascular group, but it is not having an impact on the cumulative mortality. You see, there is no higher chance to be dead, so the endovascular group is keeping an advantage after 18 years. Rebleeding was more likely after endovascular coiling than after neurosurgical clipping, but the risk was small, and the probability of disability-free survival was significantly greater in the endovascular group compared to neurosurgical group at 10 years. And now we'll go through the other parameters that was studied during the ISAT study, cognitive outcome. So there is a paper which was published in Stroke in 2010, and this is the whole population who got 1 year neuropsychological assessments. And if you look at the MRS, you see that overall this is the population that you have, but you have MRS 0, endovascular 20 versus 31% with cognitive deficit, 19% with cognitive deficit in neurosurgery, and this is the score for the MRS 2. Delayed cerebral ischemia due to acute stage. So this was studied in Journal of Neurology. And if you compare DCI, delayed cerebral ischemia, in coiling, if you have it or if you don't have it, coiling, you have less delayed cerebral ischemia than in clipping. And if it has appeared, then it is almost the same for a poor outcome at 1 year. Clipping increases the risk of delayed cerebral ischemia compared to coiling in the whole population. Impact of the ISAT study in United States. So this was also studied. And you see that impact of ISAT was important because you have an increase of the endovascular treatment during the year after the publication of the ISAT study. Looking at the length of stay, if you compare before ISAT and after ISAT, for sure you have a little bit longer length of stay in the hospital. You have decreased the mortality rate, and you have increased the cost of the procedure, even with surgery, because you are treating more patients. Aneurysm location, this is the total location of the aneurysm. You have 300 MC aneurysms that were enrolled, which is very, very low compared to what you should have. So 52% of the whole ruptured aneurysm, they were measuring less than 6 millimeters. However, only 20% of the patients with an SAH were included in ISAT, meaning that it is a randomized study, so many patients were rejected from randomization. So it is not a picture of the real life. So the question is whether or not the result of a randomized study can be applied to the whole population. And this is why it is interesting to analyze a prospective study. And as I said this morning, I mentioned this study, which is a clarity study. Every patient that were treated for a ruptured aneurysm in France during a period of time were all included in this database. And the clarity study was conducted by Laurent Spelle and Christophe Cognat. So it's an important series of more than 700 patients. It's a very nice methodology because it's a consecutive enrollment. It's a clinical monitoring which was independent for the pilot of the study, independent core lab. So it is really interesting because it's a snapshot of the real life. It's not a randomized study. So it was included in 19 French centers between 2006 and 2007. And you analyze these 400 patients that were coiled. At that time, 74 were clipped. These are the results of the treatment, and balloon remodeling, as I mentioned this morning, was used in 19%. Very few use of stents. So the morbidity and the mortality, 4% for morbidity and mortality, 1% due to the treatment, is overall the same if you compare ISAT and the MRS score at 2 months, 74% versus 72% in the clarity. And for bad outcome, 25% in ISAT, 27% in clarity. So you can apply ISAT to daily life, even in a non-selected patient. Very quickly, very few MCA aneurysms were treated, even in the clarity study. And it is just because the cause for not having the MCA aneurysm coiled were because of a parenchymal hematoma, which makes sense. It is one of the rare indications of clipping. But for 50 aneurysms, they were just clipped because they were located on the MCA bifurcation. Because neuroradiologists or neurosurgeons, they think that it's more difficult or more dangerous to coil or less difficult, less dangerous to operate, which is a very old belief. They are surviving without any rationale. Looking at this study, which was conducted in Phoenix, you know, with Spätzle, they were randomizing within the department clipping versus coiling, which is a BRAT study. Every patient, one day was for clipping, one day was for coiling during the first period of the randomization. And second, it was really randomized. And you see that a poor outcome was observed in 33% when clipping versus 23% when embolization, which is more or less the same result that was shown by ISAT. So no doubt that regardless of how the results are analyzed, intent to treat or as treated, there is a better outcome when coiling was used compared to clipping. You also have the BRAT study 3-year results, and you keep the same advantage of a poor outcome in only 30% in coil versus 36% in surgery. Finally, you know that this study was conducted, now we are in 2019. It is a 5-year study which was completed 17 years ago. And from the first case inclusion up to now, it's 22 years. And during this period of time, you have a tremendous evolution in the material. So you continue to apply the result of this study, whatever is the evolution of the technique. I just want to finish this talk with something which is funny regarding randomized study. You may know this paper, which was a joke, which was published in the British Medical Journal 20 years ago, and they were joking about randomized study. And the aim of the joke was, up to now, we have never had any randomized study to compare efficiency of the parachute against the free fall, because it is obvious. And you have a full scientific paper that analyzes why you should have a randomized study cannot be conducted to demonstrate the efficiency of a parachute when compared to the free fall. Finally, I want to conclude that we are not anymore opening the skull, but we better see the brain moving. Thank you.